An 87-year-old man is admitted to the hospital because of 4-day history of moderate abdominal cramp, nausea, vomiting. He has not had a bowel movement or pasta gas of in past 24 hours. She has a colon cancer metastatic to the lungs, liver, and duodenum. 8 months ago, he underwent a low anterior resection T3N2 rectal cancer. 6 months ago, accelerated laparotomy showed diffuse carcinomatosis and bowel obstruction, and iliotransverse bowel obstruction and iliotransverse bypass was performed. The patient and his family were informed of the findings and advised he would not be a candidate for a laparotomy in the future because there would be no surgical options to treat another obstruction. The patient has no history of serious illness, medication are 5-fluorouracil, bevacizumab. Treatment is 37.2 pulse, 100 per minute respiration, 20 per minute blood pressure. 130 by 80 millimeter mercury. The abdomen is distended, mildly tender to palpation. There are no peritoneal signs. CT scan of the abdomen show mid-jejunal obstruction, multiple intraperitoneal tumor deposits, and ascites. The physician recommends insertion of the nasogastric and percutaneous endoscopic gastrostomy tube. The patient and his family request that the patient undergo a laparotomy and intestinal bypass. Which of the following is the most appropriate next step in the management?
Ready?
Ready? Okay.
Yeah. So it's explain the futility of the operation to the family patient. Classic ethics question, the medical guidelines. We cannot do laparotomy if something does not fit medical guidelines. Okay, let's see. Wait, what was the answer again? Explain the futility of the aspiration. Explain the futility. Oof. Okay. This patient has poor prognosis due to diffuse cancer and bowel obstruction. Previous surgical exploration deemed him unsuitable for future operation due to the lack of therapeutic option. The physician is responsible for advising against intervention that are unlikely to provide benefit or may cause harm, despite the family request. The USMLE understand engaging in goals of care discussion is crucial in cases with limited therapeutic options rather than offering non-beneficial treatment. Uh, in the course of care is crucial. Okay. Recurrent bowel obstruction in the setting of metastatic cancer, especially after surgery, deemed further laparotomy is non-beneficial. Sets the stage for palliative care consideration. Associate utility of care with prioritizing comfort and quality of life rather than aggressive interventions that may not provide benefit. Mm, okay, got it.
Next. A 62-year-old woman. A 62-year-old woman comes to the office because of 3-month history of anxiety, insomnia, and frequent bowel movements. He has not had 9 kg weight loss during this period. He has not had 9 kg weight loss during this period. Pulse is 90 per minute, irregularly irregular pulse, 90 per minute, irregularly irregular respiration, 22 per minute. Blood pressure 150 by 65 millimeter mercury. She is restless. The thyroid gland is diffusely enlarged. Is heard. A bruise heard over the thyroid. Examination shows primary erythema. Some of the fingernails are separated from the nail bed. There is widening of the palpebral fissure, thickening of the skin of the dorsal of the feet, and QD orange. There is a fine tremor. Which of the following is most likely diagnosis?
Ready?
Yes,
Okay. So it's a thyrotoxicosis, most likely grave disease, methimazole first semester, PTU second and third trimester. Thyroid storm usage. AFib and hyperthyroidism go together very well. Also, like to test hyperthyroidism as anxiety. Oh, like hyperthyroidism presents as anxiety. Want me to find the other explanation, or is it clear?
no,
Okay.
ready, next.
Mhm.
Patient's information is 28 years, male, self-identified, unspecified site of care clinic, follow-up 1 week after undergoing colonoscopy, follow-up after undergoing 1 week after undergoing colonoscopy because of 3 month history of hematochezia and iron deficiency. 3 month history of loose bowel movement daily, no fever or abdominal pain. Since colonoscopy, no bright red blood bar rectum. Report show new symptoms today. Uh, physical past medical history, GAT, medication citalopram, family history. Mother and father alive with no chronic condition. Has smoked 2 packs of cigarettes daily for 20 years. He does not drink alcoholic beverages. Abdomen, scaphoid normative bowel sounds, liver span is 9 centimeter by percussion, mild tenderness to palpation over the right lower quadrant without rebound or grounding. No hepatosplenomegaly. Colonoscopy areas of qualsed ulcer with normal appearing mucosa between and involving the ileum. Which of the following is the most appropriate recommendation for this patient considering?
Ready?
1 minute, please.
Okay.
Ready.
So it is smoking cessation will help his Crohn. Smoking worsens the Crohn and overall health. Younger patient with inflammatory bowel disease, Crohn, skip lesions involving the ileum. It's not prophylactic colectomy. It's for UC. Smoking helps UC. Okay, so smoking worsens Crohn but helps UC, and for UC you do prophylactic colectomy. Colectomy. You want me to find the other explanation?
No. A 19-year-old man is brought to the emergency department by ambulance 15 minutes after he was stabbed in the 15 minutes after he was stabbed in the chest during a fight. The stab wound is located medially to the left nipple. At the scene, pulse 105 per minute, respiration 18 per minute, blood pressure 120 by 80, pulse oximeter sugar sensation 96%. Two large bore IV catheters are placed en route to the ED, and lactated bringer solution was initiated. On arrival in the trauma bay, the patient develops pulse 130 per minute, blood pressure 80 by 40. There is jugular venous distension. Results of focused assessment fast are most likely to lead to which of the following steps for this patient.
Distension. Compression. Hmm. So the cardiosynthesis. Hmm. His breathing is ready. Am
One,
I still?
yes, yes, 1 minute. Okay, ready.
Is pericardiocentesis. Left nipple where the PMI. I don't know what PMI stands for. Point of. Okay. Probably stab the left ventricle medially to the left nipple. Medially. Okay. Patient most likely has cardiac tamponade, so you need pericardiocentesis. It's not needed decompression in chest open if the question mentioned more on the lungs. Exploratory laparotomy if a person has peritoneal signs, rebound guarding. Um, CT scan of chest and abdomen with contrast after fast. It is reasonable, but this person is very unstable, so that will, yeah, probably not be the option. Let me see if they say something more important here. Pericardiocentesis. Yeah. This patient presents with cardiac tamponade. This is due to blood accumulation in the pericardial space from the injury leading to decreased ventricular filling and cardiac output. Immediate treatment involves pericardiocentesis to relieve the pressure, improve cardiac output. Fast examination will most likely reveal pericardial fluid in penetrating chest trauma. Recognize the classic triad of Beck's triad: hypotension, muffled heart sounds, jugular venous distension in the context of penetrating chest trauma to suspect cardiac tamponade. The fast exam is crucial for rapid diagnosis of trauma patient, especially when suspecting intra-abdominal or pericardial fluid. No CT scan, not the initial choice in unstable trauma patient. Exploratory laparotomy addresses intra-abdominal injuries, but the patient's symptoms suggest cardiac issue and needle decompression, and this treatment is for tension pneumothorax. So in hemothorax, like tension, whatever, hemothorax instead of pneumothorax, do we also do needle decompression and chest tube placement?
We do chest tube. Needle decompression need not
Not
to
really.
be done.
Just
Yes, because in hemothorax there is blood, isn't it?
mm-hmm, mm-hmm.
But like tube decompress tube should be given. Chest tube placement should be done. But
Even
you,
in hemothorax. Okay.
yes, even in hemothorax, yes.
Okay. Okay. Next.
A 47-year-old woman is scheduled to undergo a 47-year-old woman is scheduled to undergo right knee arthroscopy and partial medial right knee arthroscopy and partial medial meniscectomy. Medical history is otherwise unremarkable. At her post-operative examination 2 weeks ago, her surgeon discussed the risks and the benefit of the procedure. Both parties signed the operative consent from signed the operative consent form. On the patient's arrival at the hospital, the paperwork is reviewed. She is taken to the operative room and sedated, and the anesthesiology team starts her spinal anesthesia. After the patient right lower extremity is prepped for the procedure, surgical pause is taken to review the patient's name and the consent form and to confirm the site of the surgery. The operating room team is unable to locate the consent from form for review. No markings are present on the patient's extremity to indicate the site of the procedure. The surgeon says that he remembers reviewing the consent form with the help consent form with the patient and seeing her sign. The patient's husband is in the waiting room. Which of the following is the most appropriate course?
Ready?
Wait.
Okay.
Yes, ready.
It is do not proceed with and remove the patient from the OR. If you do not have consent form, you cannot do a non-emergency surgery. Option C. Do you want me to find the other?
No,
This one
no.
does.
A 30-year-old man comes to the physician because he and his wife have been unable to conceive during the past 2 years. Previous evaluation of his wife showed an abnormality. He has not been exposed to pesticide, heavy metals, radiation, testicular overeating. Physical examination shows no abnormality. Show serum studies show a testosterone concentration within the lower reference range. A diagnosis of the oligospermia is made. Which of the following is the most appropriate initial action by the physician?
Next. Oh, sorry. Ready?
Okay.
Okay. So it is ask the patient about his alcohol intake and smoking and stress level. Varicocele with overheating, not draining well. Not in regards to the question verbiage. Oligospermia decreased sperm count in sample. I don't understand what they mean. Educate the patient about declining sperm counts with increasing. This man is 30. This is a bit extreme. Let's figure out the problem first. Provide testosterone gel. This seems extreme. He does not have low libido or anything. Recommend in vitro fertilization. That's when there is infertility. Let me see if they say something different. Ask the patient about. What was the answer? Ask the patient about his alcohol intake. His alcohol. Okay. Oligospermia refers to a sperm count that is below the normal. Lifestyle factors like excessive alcohol consumption, smoking, and stress can negatively impact the sperm. Inquiry about the patient lifestyle factors can potentially identify a reversible cause of oligospermia. For USMLE, when confronted with fertility issue, a comprehensive assessment of potential reversible and modifiable factors should be the initial approach. Before moving on to specific interventions or treatment for leukosplemia, it is essential to identify and address modifiable risk factors. Recognize that common lifestyle factors, including stress, smoking, and alcohol, can affect the male infertility. Educate the patient about the declining sperm. While sperm count can decrease with age, the patient is only 30. Recommend in vitro. This is premature without first addressing the modified risk factor. Topical testosterone gel. External testosterone can further suppress intratesticular testosterone and sperm production. Okay, next.
Yes.
Oh, we are in block two.
A 40-year-old man comes to the office during the summer because of 3 days of fever, diffuse muscle ache, fatigue, and sore throat. He does not have sick contents. Medical history is unremarkable. He takes no medication. He received influenza virus vaccine this year. 10 days ago, he returned from a trip to Malaysia where he says he enjoyed the local food and the nightlife. Temperature is 101, pulse 90 per minute, respiration 16 per blood pressure 126 by 70. The remainder of the examination shown are normal hemoglobin 10, hemoglobin 10, MCD 19, neutrophil segmented 2400 bands 60% lymphocyte 5% monocyte 5 eosino eosinophil is 20% or monocyte is 20%. No, monocyte is 20%, eosinophil 4%.
Side.
Sorry, monocyte, yes. RDW is 14, normal platelet count. Monospot is negative, which of the following is the most appropriate next to
That's fever, aches, fatigue, and sore throat. Mm, mm, don't know. Enjoy nightlife. He has fever. Eosinophils is high. Some kind of parasite. Magglutination. Magglutination inhibition assay. What the hell is that? Magglutination. Ah, can it be HIV? No, not really. Between HIV and the magglutination, what is the magglutination about?
hemoglobin is for influenza. As far I remember,
As for oh, for influenza, it's not for
or
influenza.
mycoplasma.
Oh,
Usually influenza.
oh, 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 yeah, mycoplasma. Maybe. Yeah, it doesn't make sense. Monocytes is high. Monocytes, macrophages. Maybe HIV. I guess, but that would be. Oh my goodness, I'm highlighting everything. No, how can I not highlight it? Okay. Okay, so I guess I'll go with HIV. Don't make much sense, but okay. Next, ready?
Yes.
It's HIV RNA polymerase chain reaction testing. Hmm. Acute retroviral syndrome with the mono-like syndrome. Mono, oh, mono-like syndrome. Okay, this person has malaise, fatigue, fevers, anemia, leukopenia. Magglutination inhibition assay. If the body is having an antibody reaction, so not good for diagnosis. Okay, doesn't make sense. Let me see. HIV here. Recent travel to region high with high HIV prevalence like parts of Malaysia along with fever, fatigue, sore throat, and leukopenia suggests HIV. Okay. Mononucleosis like illness in the setting of negative monospotes is in a patient with high risk factors raises suspicion for HIV. For USMLE, be vigilant of acute HIV presentation when a patient has flu-like symptoms after potential exposure, including travel to high prevalence areas. Acute retroviral syndrome resembles infection mononucleosis but is distinguished by negative monospot. When interpreting symptoms, consider the patient epidemiology background, such as recent travel. It's not semaglutinin as used to diagnose mycoplasma, you're right, and then some viral infection. I guess it's the influenza that you were saying. CMV can mimic infections, but it's seen in transplant patients and immunocompromised patients. EBV has infection mononucleosis, but a negative test makes the diagnosis less likely. Next.
A 22-year-old man is brought to the emergency department by his girlfriend 30 minutes after he was found him unconscious in his home. She last saw him yesterday. He appeared well. He has a history of cocaine. He has a history of cocaine or heroin use. And he has a cocaine or heroin use, also prescription narcotic analgesic he obtains from friends. Honorable, he is lethargic. Temperature is 35, pulse 68 per minute, respiration 8 per minute, blood pressure 96 by 50 millimeter of mercury. Pulse oximetry on room air saturation is 96%. The left lower extremity is cyanotic. The left hand cold to touch. The remainder of the examination show no abnormality. Results of the serum studies are shown potassium 5.5 I, bicarbonate is low, creatinine normal, and CK is high. Each of the following greatest risk. Each of the following greatest risk.
Ready?
Okay.
Hello?
Yes, yes, yes. Sorry.
Oh, sorry, couldn't hear you. Acute kidney injury. Increased CK, so creatinine can raise mildly elevated potassium, and creatinine is okay. Patient has rhabdomyolysis, love to touch people's kidneys, so can cause acute tubular necrosis. It's not cardiac arrhythmia possible, but not enough potassium to believe that, I guess. Hypocalcemia, this is a finding, but CK is enough to push more for AKI. Let me see if this is something different here. Acute kidney injury. Of course, I'm not gonna find that one. Do you find it? Okay, carry me that question.
Wait. Yes. No. Wait.
Mm-mm.
Okay. Question 23. You found it? Okay, I'm reading 3.
20. Let me.
Just write question 23. Yes.
Okay, go ahead. You want to read it?
Okay, I'm reading. The young patient with a history of the young patient with a history of drug abuse presents with stupor, bradypnea, and a cold cyanotic limb suggestive of opioid overdose and non-traumatic rhabdomyolysis evidenced by markedly elevated CK. A common potential rhabdomyolysis as per reversible or endemic content is myoglobin-induced AKI. Illness script or test-taking strategy. In the setting of drug overdose with accompanying evidence of muscle injury, elevated CPR, always consider rhabdomyolysis and its potential renal complication. Alternatively, connect high CK in overdose patient with rhabdomyolysis leading to AKI. Okay, cardiac arrhythmia, electrolyte imbalance like hyperkalemia are not the primary risk for rhabdomyolysis. Okay, next.
Okay.
A 62-year-old woman is brought to the emergency department by her husband. 3-day history of confusion. 3-day history of confusion. He has a history. He has 20-year history of bipolar disorder, well controlled medication for the past 5 years. Her husband forgot to bring her medication bottles. Her husband forgot to bring her medication bottles and cannot remember which medication she takes. He reports that she was recently had a mild headache and has taken acetaminophen. On questioning, he says that there has been no particular change in their routine, but during the past 2 days They have been outside tennis. They have been outside playing tennis more than usual because of the onset of sunny, warm weather. While in the ED, the patient has generalized tonic-clonic seizure lasting 2 minutes. He is 163 centimeters tall and weight is 72 kg. BMI 22 kg, 27 kg per meter square. Pulse 104 per minute, respiration 18 per minute, blood pressure 140 millimeter. Examination shows dry mucous membrane. ECG shows a second degree AP block. Which of the following is the most likely responsible?
Ready?
Yes,
Okay, so it's lithium. Patient is bipolar when putting a little bit more strain on the kidneys by being in warm weather and possibly not hydrating as much. Likely that affect the kidneys and cause seizure even in therapeutic levels. Um, Clinical seizures can be likely to affect the kidneys and cause seizures can be lithium. Causes nephrogenic DI. Kidneys will be losing a lot of water. She has hypernatremia and potentiated hypovolemia. Doesn't okay. What are the other answers? Not.
question 99.
Yeah, thank you. The patient presentation is suggestive of lithium toxicity. Dehydration in the context of lithium use, especially with increased physical activity and sun exposure, can lead to increased lithium level. Okay. Could you similarly recognize that lithium toxicity can be precipitated by factors that lead to reduced renal clearance, such as dehydration? Lithium is used for bipolar disorder and has narrow therapeutic index, making it easy to reach toxic levels, especially in settings where renal clearance is compromised. Consider medication side effects of, or toxicity in patients with long history of chronic drug use and new neurologic symptoms. It's not risperidone can cause extrapyramidal side effects, but not the constellation of symptoms here. Topiramate can cause cognitive side effects, and kidney stones, but not AV blocks. Kidney stones. And bupropion, while it can lower the seizure threshold, it doesn't typically affect cause AV blocks too. Okay. Next.
Lithium can cause secondary AV block.
I guess that's what they're saying.
Let's see. Next, a 32-year-old newly gravid woman comes to the office. She has been unable to conceive for past 12 months, and her husband have unprotected sexual intercourse 3 times weekly. 2 years ago, she was involved in a motor vehicle collision. She was involved in a motor vehicle collision. CT scan at that time showed absence of the left kidney. She has no history of serious illness. Her only medication is prenatal vitamin. She has no allergies. Vital signs are within normal limit. Physical examination shows abnormal history of inflammation. When the patient conceives, she is at great risk of future. Ready?
Okay. It is preterm labor. Woman does not have kidneys. There are more likely or there are non anatomical problems, especially reproductive tract. He has an issue with uterus. If there are problems with the uterus, there will be either issues of losing the pregnancy or preterm labor, because the baby won't be able to grow until 37 weeks. Okay, let me see. This is something different here. Preterm labor. Can you find the question? Mm, mm, no.
Okay, I found it. Question 98.
Nine, 90,
98 is this one. I think so.
98. Oh, 98, you said. This one? Okay, okay. That,
Oh,
okay.
ROA, is it right?
Nine. I think yes, yes. In this scenario, the key clinical feature to consider in patients' history of a motor collision and subsequent finding of missing left kidney. This medical history is significant as it implies potential congenital abnormalities or trauma-related consequences which can impact pregnancy outcome. Specifically, the absence of kidney, whether due to congenital absence of kidney, can be associated with reproductive abnormality like bicornuate uterus. Bicornuate uterus characterized by heart-shaped divided uterine cavity is known risk factor for preterm labor. Preterm labor, defined as labor that begins before 37 weeks of gestation, can be more prevalent in women with uterine malformation due to reduced uterine capacity um, and altered uterine anatomy. It's crucial to connect the dots between patients' past medical history, especially any congenital anomalies or significant trauma, and the potential impact on pregnancy. In case of uterine anomalies like bicornuate uterus, the altered shape and size of the uterus can lead to complications such as preterm labor. Connect past medical history, especially significant trauma or congenital conditions, to potential pregnancy-related risk. It's not oligohydramnios, which will, while the renal function can influence amniotic fluid volume, a single absent kidney usually doesn't significantly impact amniotic levels. It's not yeah, that's the only one that I was confused about. Next.
14-year-old female self-identified, ethnicity unspecified, site of care of I feel lightheaded. 1 week history of lightheadedness. Almost lost consciousness during 3 episodes. Experienced tunnel vision. Almost fell when getting out of the bed this morning. Evaluated 10 days ago for follow-up of ADHD. Clonidine therapy is initiated at the time. Sister is currently hospitalized for meningitis. Patient is receiving prophylactic refund. Moderate persistent asthma that is well controlled. Last asthma examination 1 week ago. 5-day course of prednisolone was initiated at that time, which was which she completed. Attention deficit hyperactivity disorder, diagnosed at 8 years, has been numerous different medication albuterol, fluticasone, methylphenidate, chloride, vaccinations are up-to-date. Allergies for well-known allergy. Family history: mother and father alive with no chronic condition. Sister currently being treated with meningitis. Lives with parents, 18-year-old sister. She and 2-year-old sister has difficulty in school because of ADHD and hyperactivity disorder. Does not smoke cigarettes, drink alcoholic beverage, and use non-prescribed medication or other substances. No sexual and not sexually active. BP 115 on lying down and 95 and 55 after standing 5 minutes. Is it pulses paradoxes? Yes. Okay.
Mm, don't.
Appearance: sitting in a chair, not an acute distress, skin no rash, cardiac, regular rhythm, no murmur, capillary fill less than 20, sorry, less than 2 seconds, neurologic cranial nerve. An adverse effect of which of the following drug is the most likely cause of these patient conditions?
Ready?
Yes.
One question. Yeah. It's clonidine, sorry. Clonidine alpha 2 agonist that can cause orthostasis leading to vasodilation. Patient has been taking clonidine for the recent enhanced orthostatic hypotension. If systolic is going lower by 20 or more orthostatic hypotension. Okay, let me see. Let's see something here. Patient. The case is clearly orthostatic hypotension defined by reduction of systolic by 20 or more or diastolic by 10 within 3 minutes of standing. The most likely drug of options, the options to cause orthostatic is clonidine, which is an alpha 2 agonist. Remember that stimulation of alpha 2 receptors will decrease sympathetic effects. Um, yeah. Okay.
Oh, next, a 51-year-old woman comes to the office for a health maintenance examination. She feels well. She has no history of serious illness, take no medications, she smoked one bag of cigarettes daily for 28 hours, but quit 6 years ago. No pulse, 684 respiration, 12 power, blood pressure 122 by 78. On examination, pedal pulses are absent while at femoral bruise heard on the femoral bruise heard in the left lower extremity. Most often next to ready.
Yeah, it is. Wait. It is serum lipid studies. The screening question: if a person has enough RF, I don't know. Oh, risk factors. I'm getting. So a person has enough risk factor, you should screen them. Screening question. Okay, let me see if I can find another one. this one. Is it? Did you find the question?
Sorry.
Can you find the question?
Okay.
Pentoxidine. Oh,
Yeah.
I found it.
Question 7. Sorry.
Yeah. The absent pedal pulses and the presence of tremor or grit indicate peripheral artery disease. One of the most modified risk factors for peripheral artery is dyslipidemia. As such, assessing and managing lipid levels in this patient is important. The USMLE expects students to assess modifiable risk factors for this for diseases with significant mortality. Okay. With significant morbidity proactively. In peripheral artery disease, patients with risk factors like smoking, it is essential to identify and manage modifiable risk factors. Okay, such as dyslipidemia to prevent disease progression and associated cardiovascular risk. Um, okay, what was the other one? A peripheral artery catheterization, invasive diagnostic procedure reserved for patients considering revascularization. Okay, next.
A 47-year-old woman comes to office for a follow-up examination 3 days ago. She was brought to the emergency department because of cellulitis of her right lower extremity. Cellulitis of her right lower extremity. Try with the women. Sometimes this is one person can. She has had no severe. She has had no adverse reaction to the medication. He has kept her leg elevated and her cellulitis has improved moderately. She also has hypertension, gout, congenital heart disease. Her other medications are lisinopril, allopurinol, or warfarin. 5 years ago, she underwent mechanical mitral valve replacement. Temperature today is 36.7, pulse 72 per minute, blood pressure 128 blood pressure is 128 by 83. Examination show 4.25. Erythematous warm rash over the right lower extremity. Red streaking vesicles are full. There is no rash and pulse is pulse in the lower extremity is intact. Lungs are clear to auscultation. On cardiac examination, mechanical click is heard. During S1, there is a 2 by 6 murmur is heard based on the effects. Hematocrit 35, WBC count 13,000, platelet count PTT 38 normal. PT is very high. Which of the following action is most likely to have prevented the near miss?
Near miss. Huh? PT. PT play tennis outside. So it's that is fine. So it's validation factor 7. Mm, what is happening? What does she have?
Look at, I think that there may be a problem in the drug. She is on warfarin. Warfarin can
What?
raise PT. Maybe she is taking some drug which can increase the, like enzyme inducer.
But okay, they say what can prevent the near miss? What near miss? What does she have? They say they ask him what can could have prevented the issue that he
Near
has,
miss.
but I don't know what issues.
If we look at the drug, then near miss can be prevented. I am thinking in that way, may not be right.
Because she has, okay, she came to the for cellulitis. They gave her TMPSMX, no adverse effect. She was fine. She kept her leg elevated. She has hypertension, gout, congenital heart disease. She's taking the medication. She went home. Everything was fine. She had a, MV mitral valve replacement like 5 years ago. Every vitals are all normal. The rash is getting better. No rash elsewhere. Pulses are in the leg are fine. Lungs are fine. Cardiac is fine. But you can hear the S1, which is makes sense because she had the mitral valve thingy, and you can hear a holosystolic murmur. Best heard that. So it's a mitral murmur. It's holosystolic, so it's okay. It's mitral murmur holosystolic. So I guess it's bad because it's holosystolic. I don't know, but it's the mitral valve that she had protected. In labs, white blood cells are high. Okay, does she have? But she don't really have an infection. I mean, she had the infection from the cellulitis, I guess. Hematocrit is just a little bit low. Platelet is fine. PT is the only thing. PT and INR, so it's the only
The
thing that are.
PT is the thing can be raised due to
So
warfarin.
you think it's the warfarin that is causing? So what could the?
There may be
Oh,
the
okay,
recent
okay,
drug
okay. You
interacting
can.
with each other and
Okay,
causing
okay,
some
okay. That
problem.
is the drug interaction. Okay,
Ready?
okay. Yes. Review of potential drug interaction. Patient has warfarin toxicity. A drug interaction. Patient has been on warfarin for a few years. Sudden addition of Bactrim or TMPMSMX, which affects CYP450. Anything else? Let me see. Review of potential. Did you find the question? Let me
Question
see.
93.
93. The patient is on warfarin and the INR is super high. Okay, so warfarin, okay, that was a clue. Increasing her risk of bleeding, the most likely cause is her addition of TMPSMA, which potentiates the effects of warfarin. So it's C450, the 450, not an inducer the other time. Always be vigilant about drug interactions, especially when introducing a new drug to a patient on warfarin. For USM, we recognize that TMP-SMS can increase INR by inhibiting the hepatic metabolism of warfarin. So it's a CYP450, not inducer. What's the other word for the other?
Sorry. The
So TMP,
enzyme inducer, remember the most chronic
no,
alcoholics.
no, he's not. It's not TMP-SMS. Is a C450, not inducer. It's a C450. What's the opposite of the inducer?
In
Forgot.
inhibitor.
Inhibitor. Sorry, the word wasn't coming. A patient with mechanical valve is at risk for thrombosis and will be on anticoagulation. Associate an elevated INR with protection drug and interaction, especially in patients with warfarin. Okay, none of the other really makes sense. That's why I couldn't figure out what was happening. Next,
A 58-year-old woman comes to the office for a routine examination. She has type 2 diabetes mellitus. During the past 3 months, fingers stick her fingers stick blood glucose concentration and her fingers stick blood glucose concentration has ranged from 80 to 230 milligram per deciliter. Previously, they ranged from 80 to 140. Medications are metformin and aspirin. During the past 3 months, she has exercised 3 times weekly. Previously, she exercised once weekly. She follows balanced diet despite exercise and a diet. She has not had weight loss. She is 157 centimeter, 5 feet 2 inch tall, weight is 72 kg, BMI 29 kg square. Examination shows 1 into 2 centimeter arithmetic soft lesion over the posterior plantar aspect of the left foot. Sensation to pinprick and touch is decreased. Over the ankles of the feet, HbA1c is 7% is the most likely to be.
Ready?
One moment.
Okay.
Ready.
Okay. So it's A. Insulin glucose will patient with diabetes, type 2 diabetes, which is in relation to insulin receptor responsiveness. Glucose will increase, insulin will increase, and insulin receptor responsiveness will decrease. Mm, I need to look for the. You want me to look for the other
No, no.
question?
Let's jump into next question. A 57-year-old woman comes to the emergency department because of two-day history of fever, chills, and throat is on. She is on day 6 of a 7-day course of trial with the support for treatment of cystitis. She has been taking lisinopril nightly for 2 years for treatment of hypertension. She has no history of serious illness, takes no medication, temperature under 1.4 degrees Celsius, pulse is 80 per primary, respiration 60 per blood pressure 118 by 76. Examination shows erythema of the pharynx, but no other abnormalities are noted. Results of the lab studies are shown. Hematocrit 38%, WBC 2200 per milliliter uh, WBC neutrophils segmented 16%, neutrophil bands 4%, lymphocytes 64%, monocytes 16%, platelet count 225,000. Which of the following is the most likely explanation for this finding? So,
Hmm.
mm,
Ready? So
1 minute,
we-
please.
this is a weird question.
Ready.
Okay, so it's adverse effect of TMPSMX. Patient has febrile neutropenia. Vaccine favors it. Adverse, adverse side effects are floridly high. Okay, let me find. Adverse effect. Oh, did I pass area? TMPSMX can cause drug-induced granulocytosis. Okay. The recent initiation of TMPSMX fever saw the marked decrease in white blood cells with relative neutropenia strongly suggests adverse reaction. Granulocytosis is characterized by acute decrease in circulating granulocyte primary neutrophils, Recognize the scenario of a recent medication, especially TMP-SMS initiation followed by signs of infection and marked leukopenia on labs. Always review potential adverse effects of recent medications when evaluating new symptoms. It's not acute mononucleosis present with fever, subtle lymphocytosis. The mononuclear cells in mononucleosis are atypical. It is not sepsis. Sepsis can cause leukocytosis or leukopenia, but PSMS, which is a drug-induced granulocytosis. It doesn't make sense, but okay.
A 39-year-old man is brought to the emergency department because of 3-hour history of moderate pain and swelling of his right knee and ankle. His symptoms began after he scaled a wall during an obstacle course. He landed awkward on his right leg and rolled his right ankle. His knee buckled. He limped to the finish line. He underwent reconstruction of a torn right anterior cruciate ligament. 15 years ago, he and his boyfriend are engaged to be married. He feels safe at home. He does not appear to be in distress. Examination of the right means examination sorry examination of the right knee shows mild tenderness to palpation of the mid-sagittal joint line, adduction and abduction stressed as zero and higher flexion. Range of the motion is full, lackment is negative. There is moderate tenderness to palpation of the distal aspect of the fibula. There are ecchymosis over the anterolateral aspect of the right ankle. The ankle is swollen. There is no tenderness on the medial aspect of the ankle. Which of the following is the most appropriate next step?
Oh, Jesus. Mm. Oh my God, I forgot those Ottawa things. Oh, I swear, oh my God, it's crazy. It's like there's always one question in everything, but oh, Jesus, I forgot the Ottawa thing. I don't know. I'm not even going to try to think about it. Just, yeah, completely forgot about it. Ready?
Yes.
This is just. Wait, what was the answer? Ah, is that no diagnosis for the knee and then X-ray for the ankle. Question goes into length to describe that this person knees are mostly okay. Second half of the question talks about numerous issues with the ankle, but must know the Ottawa guidelines. Should we get X-ray or not? Criteria, three criteria. If you meet one, get an X-ray. One, issues bearing weight. Two, tenderness around the posterior aspect of the lateral malleolus. Posterior aspect of the lateral malleolus. Okay. Issue tenderness. Three, tenderness around the medial malleolus. If yes to one or more, get the X-ray. Okay, so I guess this is an easier way to remember.
It is
You
for ankle.
that's for the ankle. Oh
Yes.
wait,
Ottawa
it's for the
Ottawa
ankle.
rule for ankle.
It's for the ankle only.
There is no such rule for X. Sorry,
For
no such rule for knee.
the knee. Okay. I mean, the question was pretty clear. There was no issue with the knee. I got that part, but I just didn't remember the ankle one. So So if you got one of the three, either you have issues bearing weight, pain at the posterior lateral malleolus, or pain around the medial malleolus, one of the three, you get the x-ray. Okay, okay, okay. Let's see. I don't think I can find that question on the other one. So let's just, yeah. Let me see. Maybe if I put a tower. Yeah, found it. The patient's knee shows no signs of significant injury, meeting no Ottawa knee rule criteria for it. Okay, maybe I guess there is an Ottawa knee rule, but I don't think we. However, this ankle injury with tenderness at the distal fibula and restricted movement meets Ottawa ankle rule criteria, warranting an X-ray. Always consider validated clinical decision rules um, when evaluating trauma to the extremity, like the Ottawa ankle and knee rules. They can guide when imaging is necessary, ensuring appropriate care while avoiding unnecessary radiation. Okay. I guess there is an Ottawa for the knee, which is, yeah.
There is.
There is?
No, I don't think so. They
Have
have
they
said
said?
anything like that.
I don't know, but they say there is. I don't know. I mean, the explanation on that explanation said there is one for the knee, but I don't think I've ever seen that one. Oh, wait, let me see. Ottawa. Medial. No, I think it's just I just see the one for the ankle here.
Okay. A 13-year-old girl is brought to 13-year-old girl is brought to the office for evaluation of the short stature. Since birth, evaluation of the short stature. Since birth, she has been below the third percentile for her height and third percentile for weight. She has never had a menstrual period. There is no family history short stature, but her maternal uncle did not begin puberty until the age of 16 years. Her current medication is consistent with that of the 9.5-year-old girl. Pulse 82 pulmonary blood pressure attained by subsexual maturity level is 1 for breast development and stage 2 for pubic hair development. Which of the following is the most rapid in next development? Ready?
Yeah. No, it's not this one. Nope. Nope. It is X-ray of the left hand and wrist. When dealing with short stature, compare patient's chronological versus bone age. You will be looking at the hand and wrist. Okay, short status chronologic versus bone age. Let me see if they say something different here. Oop, okay. The girl's delay in growth and puberty suggests a possible bone age delay. A delayed bone age compared to chronological indicates potential for future growth with delayed pubertal development. For USME, it's essential to recognize that X-ray of the left hand and wrist bone age study are used to assess skeletal maturity and predict future growth potential. Delayed growth and puberty with a family history of head bloomers suggests constitutional growth delay. Always relate clinical features like short stature, no menstruation, no delayed breast development to the most appropriate diagnostic step, bone age assessment. It's not X-ray of the long bones and spine, more related to evaluation of skeletal dysplasia and pathologies, not assessing growth potential. What was the other one? CBC and serum chemistry useful for metabolic issues, but not specific for evaluating growth delay. Okay, next.
A 20-year-old woman comes to the office because of 1 year history of lump on her left ear and appeared 2 months after she had ear pierced. Physical examination shows the finding of the photograph which of the following is the most appropriate initial treatment. Isn't it keloid?
You think so?
What is your diagnosis?
I
Like,
don't know. Do we exercise or do we give steroids? Whenever this is keloid, do we exercise or do we give steroids? I feel like we give steroids. I don't know. I don't know.
really?
I thought you pierced the thing here. You don't pierce it here. Okay. Mm, wait, wait, wait. Because you pierce the left in the ear here, not all the way at the back. Needle aspiration, laser ablation, cryotherapy. Okay, whatever. Ready. It is corticosteroid injection. This is most likely a keloid, first line steroid, inhibiting fibroblast therapy, but second line uh, cryotherapy. Wait. So first line is steroid injection, and second line is cryotherapy. Let me see if I find something else. Yeah. Ugh, that's not the answer. That's not the right thing. Let me see. If I put keloid, there you go. Keloids result from overproduction of collagen during wound healing. The most effective treatment for smaller keloid is inject steroid. Intralectional steroid injection helps reduce the size and itchiness of the keloid by decreasing collagen synthesis and increasing collagenase activity. For USME, remember that keloids often occur after ear piercings and can be distinguished from hypertrophic scars as they grow beyond the boundaries of the original wound. A history of lung formation after ear piercing, especially in young adults, strongly suggests keloid formation. Initial management choices of USMLE often favor conservative options that can be performed in an outpatient setting before considering more aggressive options. Cryotherapy, more commonly used for warts in actinic keratosis. Laser ablation, reserved for cases that do not respond to conservative measurements. Wide excision surgery can sometimes clear larger keloids, especially without concurrent therapies. Okay, got it. Next. I
A
want to take a
42
break.
year old, sorry,
I say I want to take a break when we started so late, so I guess there is no break today. Let's just
can take a break for, okay, let's take a break.
yeah.
A 42-year-old woman a 42-year-old woman is brought to the emergency department by ambulance 20 minutes after a 20 minutes after a head-on motor vehicle collision in which she was the restrained driver in which she was the restrained driver. Honorable, she is alert and reports of chest and abdominal pain. Medical history is unremarkable. Medical history is unremarkable. She takes no medications. Temperature 36.7 degrees. Pulse 120 per minute. Respiration 28 per minute. Blood pressure 130 by 80 millimeter mercury. Pulse oximetry 4 liter per minute on oxygen via nasal cannula. shows an oxygen saturation 90%. Breath sounds are decreased on the right. Trachea is in the midline position. Cardiac examination discloses no abnormality and abrasion. An abrasion consistent in shape with a seat belt is present over the right upper abdominal quadrant. The area is tended to palpation radial and dorsal pedis pulses. Normal bilaterally. Results of the lab studies are shown. Arterial blood gas PO2 65%, PO2 65%, PCO2 32%, pH 7.38, hemoglobin 10. Chest X-ray is shown in addition to IV analysis. Which of the following is the appropriate next step? Okay, ready?
One moment. Okay, ready. It is tube thoracostomy. This is the image indicative of pneumothorax. How do you train pneumothorax? To tube basement. Let me see if the thoracostomy. Given the trauma history, decreased breath sounds on the right, and arterial progression in hypoxia, the scenario is consistent with traumatic hemothorax. Okay. The USME expects students to know that tube thoracostomy is the immediate management for hemothorax. Okay, so hemothorax doesn't have the needle, I guess. After trauma, especially car accidents, look for classic signs like decreased breath sound, chest pain, hypoxia. Normality is consistent with seatbelt signs like those on the right abdomen, upper abdomen, also one of possible internal injury. It's not thoracotomy, is invasive procedure for non-responsive cases. It's not thoracocentesis, is pleural effusion. It's not intubation or mechanical ventilation. The patient is not in respiratory failure. Okay. Next.
Yes. A 31-year-old woman comes to the office because of 3 month history of intermittent non-bloody diarrhea. The first episode began 5 days after a camping trip in rural Virginia uh, with her family. During the trip, she drank a spring-fed pond. Says that it was clean during weight loss, no
Okay.
appetite.
Stop
Sorry,
reading. Stop reading. Can you give the answer now with the picture of what you read?
is it giardia?
Think so. I mean, you have the non-bloody and then you have the picture.
And
I was only
there is a like how taking water from the spring-fed pond.
playing fair phone. I was between it and I don't remember what Entamueba looked like, but I
Histolytica
know
bloody diarrhea. Intermittent
yeah,
histolytica
it's
is
bloody
bloody.
diarrhea. That's why I let you start reading. But once you say non-bloody diarrhea, I was like, okay, I think I know what it is. You
Okay.
want to see?
Yes, yes. See,
Okay, it is Giardia, treat with metronidazole. Freshwater drinking from camping, weeks, months, history of diarrhea, not bloody. Not bloody, so it's not so it can be C. diff, it can be E. coli, or it can be Giardia. Okay, next. Oh, it's one of the long questions. Oh no, it's not the one question yet.
A randomized placebo-controlled trial is conducted to assess the effectiveness of a serum for chemoprophylaxis of the breast cancer. Which of the following represents the ARR absolute risk reduction for invasive breast cancer per 1,000 women in those treated with the serum?
Ready?
Yes.
Okay.
Is it 13 minus 7? That one.
Nope, we were wrong. It is 2.6. Oh, sorry. It's per. It says per woman. Invasive breast cancer per thousand woman
Woman,
years. In this, okay, we just look at. I just look at invasive cancer.
I also
But
look
yeah.
at this
Okay.
per 1,000.
Yeah, per 1,000, whatever. So it will be the 3.6 minus the one. I mean, but we know how to calculate. You knew how to calculate it.
Yes.
It's just that, yeah, we didn't. Yeah, that's why. Yeah. Next. That's one of the long questions. Okay.
This is a near miss. Okay. A 57-year-old woman comes to the emergency department 1 hour after vomiting, 1 hour after vomiting bright red blood. So bloody vomiting, bloody. She drinks it was. She thinks it was approximately 1 cup of blood. She reports that during the past month she has felt full sooner than usual while eating. She has not had other episodes of vomiting and has not had weight loss. She has no history of operative procedures. She has hypertension and type 2 diabetes mellitus. Medications are hydrochlorothiazide and metformin. She has not taken aspirin or non-steroidal anti-inflammatory drugs during the past month. She does not smoke cigarette, drink alcohol, or use other substance. Temperature 37, pulse 116 per minute, respiration 16 per minute, blood pressure 110 by 78. Examination shows mild tenderness to palpation in the mid-epigastric area. There is no rebound tenderness. Test of the stool for occult blood is positive, hematocrit 31%. Platelet count 2,40,000. Prothrombin is 13. In addition to IV, in addition to IV administration of fluid and nasogastric tube, which of the following is the which of the following is the most appropriate?
What does she have? Diabetes and hypertension. Mm, 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 mm. Yes, colonoscopy. Ready?
Yes.
Okay. Am I in the right place? Yeah. So it's EGD, esophageal duodenoscopy. Coughing up blood, epigastric pain, most likely peptic ulcer disease. Orient yourself before answering the question. This person has GI bleed, Give the person fluid, two IVs, then EGD. Okay, so coughing about the epigastric pain is peptic ulcer. GI bleed, so you give IV fluids, intravenous IVs, and EGD. If nothing in the upper GI, then you do a colonoscopy. Okay, that's how it works. And it's not octreotide. That's for the octreotide scan is for neuroendocrine tumor. Tectenium is for Meckel diverticulum. Mesenteric angiography is for mesenteric ischemia. Let me see if I find that question. Esophago, gastro. Oh, did you find that question?
Wait,
I found it. The patient presentation of vomiting bright red blood suggests an upper GI bleed. For USMLE, recognize that EGD is the first line diagnostic and therapeutic approach for suspected upper GI bleed due to its direct visualization of bleeding source in the esophagus, stomach, and duodenum. When faced with case of hematemesis, always consider EGD as the best initial diagnostic approach. Consider the location, upper versus lower GI, nature of bleeding, bright red blood versus melena, and clinical context. It's not CT, not the first line for GI bleed. Octreotide is used for local. Octreotide scan is used to locate sources of ectopic endocrine activity, not direct bleeding. Tecenion is detects slow GI bleeds. Colonoscopy evaluates the lower GI. Mesenteric angiography is used for intermittent bleeding when other methods fail. Sorry. Yeah. Okay. I just thought it was colonoscopy because she has upper GI and also the occult blood is also positive. So I was, I guess it can be okay, okay. It can be that she's bleeding from the top and it's going to the back. Okay, next.
after IV administration of fluid and nasogastric tube, the patient undergoes esophageal gastroscopy. Autograph of the endoscopic is shown. Which of the following? Which of the following is the most appropriate? Endoscopic goes. There is bleeding, isn't it?
Mm. Yeah, I'm thinking this thing is bleeding, right?
Ready?
One moment. Yeah, it is endoscopy hemostatic therapy. You can immediately fix it immediately. Okay. Active bleeding in EGD, fix it right away. Okay, let me see. Maybe this one will be the next one. Okay. The patient presentation is sudden hematemesis, might meet epigastric pain, and positive stool for cord blood suggests upper GI bleed. For USMLE, immediate endoscopy hemostatic therapy is the appropriate management if an active source of bleeding or a high risk lesion is identified in the EGD. Sudden upper GI bleed, especially with findings of high risk lesion on endoscopy, should prompt consideration for endoscopic intervention. It's not omeprazole, it's for peptic ulcer disease, not for bleeding. Opioid therapy for variceal bleeding due to portal hypertension. Endoscopy resection used to removal of tumors of polyps. Okay. Nice.
A 77-year-old a 77-year-old woman who resides in a skilled nursing facility is examined by a physician one day after noticed some blood in the bedsheet. She sustained she sustained a cerebral infarction 8 years ago. She has confined to the bed since then because of residual left hemisphere. She is currently taking warfarin. She is 160 centimeter, 5 feet 3 inch tall. Weight is 50 kg, BMI 20 kg, body risk for temperature 36. pulse 70 per minute, respiration 18 per minute, blood pressure 180 by 90, blood pressure 180 by 90 millimeter of mercury. There is no lymphadenum, but the examination shows small clean decubitus ulcer on the sacrum, small clean decubitus ulcer on the sacrum. Pelvic examination shows a 3 centimeter raised fleshy lesion, 3 centimeter flesh lesion on the right labia major. Vaginal examination cannot be performed because of patient's vaginal examination cannot be performed because of patient's discomfort. Which of the following is the most appropriate? Fly.
Ready? Omar?
Yes, yes.
Oh, okay. Couldn't hear you. Sorry. Is biopsy of the vulva? They are taking care of the decubitus also, so look at the vulva lesion. Wait, one moment. Biopsy. The presentation of raised fleshy lesion of vulva in an elderly woman is considered for vulvar cancer. The most definitive way to diagnose is through histological exam. The USMA expects students to prioritize biopsy for suspicious lesions to establish diagnosis. The presentation of raised fleshy lesion on vulva in an old woman is concerning for vulvar cancer, and the most okay, they are repeating the same thing. Cytological value of the vulva, not the primary method for diagnosing vulvar cancer. Colonoscopy not relevant. Okay, nothing is relevant here. Next.
Yes. A 68 year a 68-year-old man comes to the office because of 3 month history of moderate low back pain. The moderate low back pain that extends into both legs. He first noticed the pain while standing in the ticket line at the theater. At the time, the patient was accompanied by tingling in his both legs. The the symptoms recurred a few days later after he was standing in the grocery checkout line. The pain has not responded to ibuprofen or naproxen but improves with sitting or lying down. Prior to the onset of the pain, the patient typically walked for 30 minutes 4 times weekly. He discontinued his walking regimen 2 months ago because it seemed to trigger his back pain. He has hypertension and hyperlipidemia. Medications are hydrochlorothiazide, simvastatin, aspirin. The patient has smoked 1 pack of cigarettes daily for 14 years. Pulse 74 per minute, blood pressure 140 by 90 millimeter mercury, lungs are clear to oscillation. Expiration phase is delayed on cardiac examination grade 2 by 6 systolic crescendo decrescendo murmur is heard at the right upper sternal border. There is trace ankle edema bilaterally ankle brachial index is 1 musculoskeletal and neurologic examination shows no abnormal which of the following is the most likely diagnosis.
ready?
1 minute, please. Ready.
So it's spinal stenosis, damn it. Spinal stenosis, vertebral discs get smaller, compression is getting worse. If you curve the spine, reduction of space. If NSAID downward, look for spinal decompression. Okay, that makes sense. In certain positions, when putting pressure on the spine, like walking or standing straight, there is pain. Pain is relief when pressure is relief. Neurogenic claudication. Uh, Wait, what did I pick? Peripheral. Oh, that's what. Never mind. I didn't even look. What is the next best step in management of patient that presents with suspected lumbosacral radiculopathy, sciatica, after lifting a heavy box? Strength leg test is positive and urologic exam is unremarkable. Um, you do trial of NSAID and acetaminophen. Imaging in herniation is controversial. It doesn't change management. Therefore, no MRI for just back pain plus positive straight leg raise test alone. Let me see. I think that one is pretty clear. I just read the answer wrong. Um, okay, let me see. Maybe they say something different on the other one. Spinal stenosis. Mm, okay. Patient symptoms of back pain radiating to both legs, exacerbated by standing or walking, relief by sitting or flexing the spine are typical for neurogenic claudication due to lumbar spinal stenosis. Age and degenerative changes are common causes of lumbar spinal stenosis. For USME, understand that spinal stenosis present as pain or tingling in lower extremities, worsened by lumbar extension, so standing or walking, relief by flexion, sitting. Always differentiate between neurogenic spinal stenosis and vascular cavitation. The relief with flexion and pain with prolonged standing or walking are hallmarks of the spinal stenosis. Recognize that the onset of symptoms during activities involving standing or walking is a clue for spinal stenosis. I think that was the other thing I was confused with. Okay.
Next. A 50-year-old a 50-year-old man comes to the office because of 3-day history of mild headache, intermittent confusion. He has 30-year history of schizophrenia and 5-year history of emphysema. Medications are clozapine, sertraline, and dexamethasone and salmeterol. He also receives home oxygen therapy. He smoked 2 packs of cigarettes daily for 33 years and but quit 5 years ago. Temperature 36.8 pounds, 90 respiration 20, blood pressure 115 by 70. Examination shows mastomy was never lungs or clear toss condition. There is no peripheral neurologic examination. No findings. Results of blood count are within reference range. Sodium 116 very low, potassium 4, urea nitrogen 20, creatinine 1, glucose 100. Which of the following is the more appropriate next?
It looks. Okay.
Yes.
So it is measurement of urine and plasma molarity. Okay, let's just be done for today. It's not going good. Emponatremia due to SIADH. Sertraline can cause SIADH. Did not know that. Urine and plasma molarity syndrome of SIADH. The causes: CNS disturbance like a stroke, medications like SSRI, NSAID, and carbamazepine, lung disease like pneumonia, pain or nausea, ectopic ADH secretion like small lung cancer. That's what I thought it was. Clinical features: mild moderate hyponatremia, nausea, forgetfulness, severe hyponatremia like seizure, coma, and hypovolemia. Lab findings: hyponatremia serum osmolarity will be, I guess, low. Urine osmolarity will be, I guess, high. Urine sodium will be more than 40. Management: fluid restriction, salt tablets, hypertonic saline for severe hyponatremia. Wait, let me see if they say something different here. Oh, what's the answer? Measurement of urine. Yeah. Did I pass it? Okay, right here. The patient presentation includes confusion and a low serum sodium, indicating hyponatremia, which require differentiating between the various causes. Measuring urine osmolarity helps to differentiate between hyposmolar hyponatremia and other causes. While plasma osmolarity further specifies the type of hyponatremia. For USMLE assessing urine and plasma osmolarity is the next logical step in evaluating causes of hyponatremia. Hyponatremia can manifest with non-specific CNS symptoms like headache, confusion, and seizure. Determining whether the hyponatremia is due to water retention, salt loss, or mix of both is essential. It's not chest, CT scan of the chest. This patient confusion is more likely related to the hyponatremia. Okay, okay. We can we stop here today?
Yes. Yes.
Okay, we have done now.